Do you have fall yet in Spain?
Pardon me?
Do you have fall yet?
Starting to, but it's pretty warm actually. It was the warmest day. Yesterday was the warmest day in October in France ever.
Oh God!
Wow. Yep.
Okay, so I would like to welcome everybody to the liver cancer program talk for today. And I have the privilege and honor and joy to introduce Bruno Sangro from Navarra, Spain. Usually if we prepare for these talks, we ask the speakers to send their bibliography so that we can introduce them and name all their awards and everything. And Bruno probably sent the briefest summary I've seen in a long time. And this is because everybody knows him. He is like Mr. HCC. He is obviously, the president of the ILCA. Everybody that works in the field knows that he spans a huge expertise, beginning from immunology over interventional therapy to hepatitis, HCC, immunotherapy. But nevertheless, let me briefly tell you so that, obviously he graduated from medicine in Madrid a number of years ago, and then started in Navarra, where I think he has always been at Navarra, if I'm not mistaken, throughout his training. And currently he is a professor and director of the liver unit and co-director of the hepatobiliary pancreatic oncology area at the Clinic Universidad de Navarra in Pamplona, Spain. He's also a professor of internal medicine and leads active research groups in the Spanish network of the biomedical research on hepatic and digestive disease, focused on therapeutic innovations in the field of liver cancer. And now I actually have to correct myself. He's a past president of the ILCA. I thought he was still the president, but this doesn't make him any less important. And I'm very, very pleased to have him give his talk today. And the title of the talk is A Second Look at Immune Interventions in Liver Cancer. Bruno.
Thank you very much, Tim. For the audience, just please be aware that all these kind words are based in friendship. And I probably don't deserve most of them. But it is true that I've been dedicated to liver cancer from the very beginning of my clinical and research career. And yes, it is true that I've spent all but 4 years of my training and then professional career in the University of Navarra. And this is in northern Spain, close to the French border. And this is where the place I work looks like. This is the hospital. It's a medium-sized southern European city. This is the hospital. This is the School of Medicine. And these are the research facilities. So, and I think this has allowed us, and particularly has allowed me, to have a good interactions between teaching, doing research, and attending patients in the clinics. And I think this is why the focus of my activity has been basically on how to do research to improve patient outcomes. A bit of conflicts of interest, and I think this is important, not because there are interests and there are many, because it would allow me to say that much of the data that I will present, and I will present a few original or fresh data, but what I would try to do today, and that's where the title comes from, is to have a second look on things that have been there for some months or years, but I think they can be looked in different perspectives, and much of the things we ignore are much more important than the things we already know. And we've been involved in clinical trials on our own for several years, and also with industry. And I think this is important because we need interaction with the industry to really understand how to better evolve therapies to make them more beneficial for patients. And also as a starting point, let me remind you these data about the incidence and mortality of liver cancer, because all the papers on HCC start by saying HCC or liver cancer is this fifth or sixth most frequent cancer and the second or third cause of cancer-related death. But the actual numbers is around 800,000 new cases per year, with mortality also always almost equaling incidence. And speaking of how terrible the prognosis of these patients is when they are diagnosed. And recent data indicate that unless things change, and hopefully they will change to some extent, these figures will increase by more than 50% by 2040, reaching almost 1.4 million cases. So we need to do something to change this mortality. And just as a brief introduction, there are a few things that are special about liver cancer as opposed to any other cancers. One is the resectability. If you think about breast or colorectal cancer, they are almost always resectable. The decisions to resect are not based on technical issues. This is not the case for liver cancer because the underlying cirrhosis in most of the cases. And the other important difference is that until very recently, we lacked systemic therapies because it's a very chemo-resistant tumor. And so we make use of local regional, particular intra-arterial therapies in a wide variety of patients with different stages from early to quite advanced. So these are two things that I have to take into account when they consider liver cancer. And as for systemic therapy, there was almost nothing there until more than a decade ago when sorafenib was introduced. But the field has changed entirely over the last 2 to 3 years. And this is because immunotherapy has been shown to be active in some groups of patients that we will discuss very soon. And it's really, this slide highlights the fact that it's all about immunotherapy now. And that's the reason why we should take a closer look at the data that we've already gathered if we want to move the field forward in a meaningful way. And probably this started with this trial we had the opportunity to run some time ago. And this was basically because at that time, Pfizer, who owned tremelimumab, the CTLA-4 blocking agent, was interested in hepatitis C, and we convinced them that it was worth doing a trial testing for the antiviral as well as the anti-tumoral activity of CTLA-4 inhibition. And then, you know, the data, response rate of higher than 15%, some long-term stable diseases as well. In terms of biomarker analysis, we did what we could at that time. It was clear that there was an increase in interferon gamma and IL-6 signaling in peripheral blood. And when we analyze circulating cell subtypes, we were only able to see in a few patients an increase in CD4 positive, FOXP3 positive cells. I wish we could have those cells and samples now. When we tried to analyze if there were responses that were induced by therapy, at that time the technology was not there. We collaborated with Robert Timmer in trying to analyze AFP responses, but the data were not really too convincing, and neoantigens were not really a state-of-the-art thing to do. So from there, we escalated to PD-1 inhibition, and this is a phase 1 dose escalation study that we first thought we could do as an ISR. Then BMS took this as company-sponsored trial, and this evolved to the Checkmate 040, which is a basket trial with a number of different cohorts, as you may know. And this has eventually evolved to different phase 3 trials, interrogating if in systemic therapy naive patients, single agent PD-1 or PD-L1 blockade could indeed improve survival. And it was clear that overall survival was not improved. Non-inferiority has been proved for durvalumab and tislelizumab. And basically, if you look at the survival curves, you can see that they overlap very consistently over the first 3 to 6 months and then start separating. So that also very consistently, there is an increased number of long-term survivals among patients treated with PD-1 or PD-L1 inhibitors. And this is basically the result of a small subgroup of patients responding by showing significant tumor shrinkage, tumor responses that are associated with a very prolonged long-term survival. And for instance, in the Checkmate 040 with a large cohort here, sorafenib experienced patients, you can see that more than 50% of them were still alive 5 years after treatment initiation, post-sorafenib, which is quite remarkable. But this is a small subgroup of patients. And there are other patients that achieve this durable, stable disease. And nobody has yet interrogated if these long stabilizations are really associated with an increased potency of the immune response, whether by T cell activation or any other kind of way that you can think the immune response can be elicited or it reinvigorated. And I think this is a point that we need to address when we consider what patient benefit is, because patient benefit is not only responding to therapies, probably also achieving these prolonged stable diseases. Who are these patients? And this is a critical question for clinicians and researchers. Well, certainly they are not patients with a particular site or degree of tumor burden. Responses can occur irrespective of tumor burden or locations. They are not specifically patients with high or low AFP levels or with one etiology of the tumor or another. You can achieve a similar number of responses across etiologies. So when we collected the biomarker samples for biomarkers in the Checkmate 040 phase 1 and escalation, which is a pretty big number of blood samples, not so many samples available for gene expression profiling. But what was clear, as it happens in other tumors, is that yes, you do see higher number of CD3 cells in patients who respond. Not really lots of difference between stable disease and progressive disease. No significant signals for other subtypes. Yes, if there was an increased number of PD-L1 expressing cells, either tumor cells or stromal cells, or the combinations, you had a higher chance of responding and a higher chance of surviving longer. But again, you could still have long survival and objective remissions if the number of PD-L1 positive cells was reduced. And yes, again, any inflammatory gene signatures that you can imagine was associated with a higher response rate. And again, no difference at all between stable disease and prolonged disease, which is something that we have not paid enough attention yet. So this is good for publishing, but we need to focus on clinical benefit outside clinical responses. So we had the opportunity to check for additional biomarker analysis in the larger cohort of the Checkmate 459, a trial that is was comparing nivolumab versus sorafenib. again, if in this case, if you look at tumor mutational burden, there was no sign of improved survival or response based on TMB. It was a higher response and survival outcome in tumors that had T-cell inflammation signatures, and this was not the case for some of the good candidates in terms of tumor cell features that could be associated, and this was largely based on some studies coming from the US with immune excluded tumors like beta-catenin. Here you can see that there was indeed a difference between beta-catenin mutated or Wnt beta-catenin pathway altered tumors when they were treated with sorafenib, but not when they were treated with nivolumab, as was expected from the preclinical data coming particularly from Mount Sinai. And again, now in gene seed expression analysis, you can see a number of genes enriched in responders that are related to the immune response, PD-1, CD8, chemokines, etc. But when it came to analyzing the results in this was certainly present in responders to nivo, but we're also present in responders to sorafenib, and we lack convincing evidence that sorafenib is acting through modulating the immune response. And when it comes to survival, yes, again, inflammatory signaling upregulated in patients with a longer response after nivo, and this was a difference with patients treated with sorafenib. So altogether, if we put all this data together, my perspective is that we may have put a lot of emphasis on what is happening in the tumor microenvironment and maybe missed or not paid enough attention, maybe because it's more difficult, to what is happening in the earlier phases of the immune response, where the T cells become activated and start proliferating. And we have to rethink if what we see in the tumor microenvironment, and particularly what the changes that we see in the tumor microenvironment are really the consequence of PD-1 inhibition of the PD-L1, PD-1 interaction in the tumor site, or rather in earlier phases of the immune response. Of course, more difficult to answer those questions because of the lack of adequate samplings in most cases. Anyway, this was clearly a situation where other things had to be done, and then the focus was placed on combinations with CTLA-4 inhibitors, VEGF inhibitors, and tyrosine kinase inhibitors. You all know a number of combinations with VEGF inhibitors, bevacizumab, or small TKIs, all of them positive, all of them showing this early separation of the survival curves, meaning that more patients were benefiting for treatment. And we now here have some also analysis from the Roche trial. I did not participate in this trial. And again, you see signatures of inflammation being upregulated in responders versus non-responders, something that you would have expected with atezolizumab alone. Higher, so similar with that monotherapy of PD-1 inhibitors, higher increase in CD8 positive cells and CD3, PD-L1 positive cells, and they also correlate these CD8 infiltration with PFS and overall survival, something that was clearly expected. Similarly for these T effector signature, and what is interesting is that in these, Roche had the opportunity to test in a small cohort of patients in a phase 1/2 trial that was randomized to receive atezo-bev versus atezo only, and they were able to see that the added benefit of bevacizumab was certainly more intense for patients showing these T effector signaling signature as much as it was for patients showing high CD31 based vessel density. So it is not only the anti-angiogenic effect that is driving probably the benefit of the combination, it's also to some extent the effect on the immune response. And among the different actions by which VEGF can inhibit or CTL expansion and activity, but also the modulation of the other negative actors in the tumor microenvironment. I think this is something that still needs to be explored. We have had the opportunity to collect in this phase 3B single-arm study in which patients were treated with atezolizumab plus bevacizumab, regular dosing. We were able to collect in a few tumor samples because samples were not mandatory, but a large number of blood samples. These were 100 patients, and 90% of them have succeeded in collecting all the three time points. And we are now very actively doing an extensive biomarker project with these samples that will help us probably understand better which patients are truly benefiting for the combinations and how can we further expand the activity. In terms of CTLA-4 inhibition, as you've seen, the HCC is clearly a CTLA-4 sensitive tumor. In the Himalaya trial, the combination of a single priming dose of tremelimumab with regular dose of durvalumab was able to increase objective responses and, what is more important, to prolong survival, and particularly prolonged long-term survival. And to me, and this is something that we will address in the coming months, we need to figure out what is the precise mechanism by which one single dose in the beginning of a CTLA-4 inhibitor is able to induce very prolonged anti-tumor effect. And my perspective is that definitely it is unlikely that this is a result of the effect on the tumor microenvironment with such a short-lived exposure to the agent. It's probably something more related to priming of immune response. And this is clearly, this notion is clearly also supported by the fact that when you look at the peripheral compartment and see the kind of cells that are expanded shortly after treatment, you see that there is a subset which are basically CD8 positive, Chi 67 positive, so proliferating cells. And these cells are, this expansion is associated with response with this combination, but also you can see here in all cohorts treated with tremelimumab or durvalumab monotherapies. So again, this brings us the opportunity to see that indeed the peripheral compartment could provide meaningful signals, not as to which patients could benefit most from treatment from the beginning, but certainly while the treatment has just been initiated. And I think this is going to be important in the design of new trials where new therapies have to be added on or de-escalated. And finally, we've got recent data from the combinations of atezolizumab or pembrolizumab with TKIs, cabozantinib or lenvatinib. Both trials showing no superiority in overall survival. In the case of cabozantinib, showing no effect at all. In the effect of pembrolizumab plus lenvatinib, showing no effect for the majority of the patients, separation of the curves that starts more than 1 year after treatment was initiated, leading to a small increase in long-term survivals at 2 years. And of course, there's been a lot of debate on as to what was this the case with such interesting data coming from early phase single-arm trials. And to me, one of the reasons that has to be explored is that indeed TKIs could really blunt the immune response in a subset of patients as much as they can reinvigorate T-cell activations in some others. And this is, we really lack, and we really are eagerly awaiting for the biomarker data of these trials, because the few data that have been published is that this is a neoadjuvant cabozantinib plus nivolumab trial. A few patients, only four here, were treated with cabozantinib, have paired biopsies, and you can see that there is an upregulation of good actors and bad actors, so genes that could be associated with either activation or deactivation of the immune response. And so the role of TK inhibitors in the immune response in HCC, I think, still has to be correctly understood. And now the field is evolving, and now these immunotherapies are being tested in much earlier stages, and this will certainly inform what we have to do next. But I think this is particularly interesting when you focus on the intermediate stage, when the immunotherapy is going to be combined with other forms of therapy that intrinsically may have immune-relating effects. And one of this is radioembolization as a form of radiation therapy. We had the opportunity to run this trial, NASER, in which we combine radioembolization with nivolumab, with a gap of 3 weeks between cert and nivolumab initiation, 41 patients treated, and we were able to collect tumor samples from all of them, and then repeated blood samples. We are in the process of analyzing. I will provide you with a very few data that I can present today. Well, basically say from a clinical perspective, response rate was up to 40%, which is slightly higher than one would expect with cert alone. TTP around 9 months, median OS around 21 months. Again, slightly higher than what would expect in these populations, but not surprisingly higher. And this made us be very active in doing the biomarker study to trying to understand why the results were not extraordinarily good, I would say. And we've analyzed these, trying to capture clinical benefit, and not only by analyzing patients who respond, but also those who have sustained disease, stable disease sustained for more than 6 months, or responders that had their response sustained for more than 6 months. And that make more than half the patients. And this is a clinical variable for dichotomic analysis that is able to differentiate, well, time to progression and overall survival. So it's clinically meaningful. We just presented at ILCA when we analyzed in this small group of patients, TMB, no effect on clinical benefit, no effect on progression-free survival. And when we tested not TMB, but predicted class 1 and class 2 neoantigens, there was no signal for class 1 neoantigens, but there was a signal for class 2. And you can see that the number of neoantigens total, or of those that are came from expressed genes there, they were higher among patients with clinical benefit, and that translated into more prolonged progression-free survival. In terms of cytokines, a few data that was interesting is that individual cytokines, there were not too many changes, but there was an association between higher increases in CCl4 and lower increases in nitric oxide syntase among patients with clinical benefit or more prolonged PFS. But I do believe, and this is the work we are doing now, that we have to interrogate a cytokine not in an individual level, but rather in an integrated way, because it's unlikely that individual changes will give you any clue as to how to perform. And then as it relates to the tumor infiltrate, again, very scarce data that they can present, but I can tell you that you can see here for CD3 PD-1 positive or grandson B positive, they, contrary to what we expected in the beginning, the abundance of these subsets was lower in patients with clinical benefit than in patients without clinical benefit. And so this is a trial work that we're actively doing now, but I can share with you that our hypothesis today is that radiotherapy is activating the immune response in patients in which the immune response is not so active at baseline, and at the same time maybe blunting the immune response because it's radiation to the tumor microenvironment. Don't forget that in some other group of patients. And so there is a pro and con in these kinds of combinations that we have to disentangle if we want to perceive this meaningful forward in a meaningful way. Very rapidly, a few words about other things that we are doing. We're interested in therapeutic vaccinations as a way to enhance the activity of PD-1, PD-L1 blocking agents. We were involved in this European trial, HEPAVAC, trying to find a universal therapeutic vaccines. The peptidome and the mutanome of HCC tumors being analyzed, and those peptides that were common to a number of different patients were formulated into a universal vaccine, and the patients were vaccinated, were not treated with anything else. And this is already published this year. Basically, what we were able to see is that there were immune responses that could be identified in a number, I would say a reduced number of patients to these universal vaccine, but this did not translate into any clinical benefit at all. So certainly universal vaccination is not the way to go. What we are interested in is in personalized vaccines. We've done some jobs and trying to establish the platform to identify individual neoantigens and make this information available for active vaccination downstream in the patient journey. And this is also work in progress. We are planning to have a clinical trial started somewhere by the end of next year. And finally, we also have interest in adoptive T-cell therapy, and there's been some aims at using CAR T-cells, I would say, with challenging results in terms of safety. We've collaborated with industry in TCR engineered T-cells with this Adaptimmune clinical trial, in which the autologous cells were engineered to bind alpha-fetoprotein with high affinity. And basically, the results of these trials, the treatment was very well tolerated, very few relevant adverse events. And what is interesting to me is that there were a number of very prolonged stable diseases and one complete response. And that was one of our patients, in that indeed when upon progression, what happens that progress in different tumor sites. So it was not the prior sites that were progressing, and this has been now followed for a very prolonged period of time. And this is a proof of principle that if you have T cells recognizing relevant tumor antigens, adoptive T cell therapy could be beneficial. The problem is you need to have the right target, the right antigens, and alpha-3 protein is certainly not probably the right one to go. We will have to go to the platforms of individual privative neoantigens probably to make the most of this. And this is what we've also been trying to do, analyzing neoantigen-specific peptides in tumor samples, and also very preliminary work from the lab from Sangro, showing how if you challenge the patient cells with different pools of peptides and covering the entirely repertoire, then you are able to identify pools of peptides that can really induce CD8 responses in the tumor infiltrating cells. So altogether, I think basically what we have learned is that we ignored much more than what we know, that we need to integrate all the information that we've gathered over the last 2 to 3 years, both independent researchers and pharma industry, because it is unlikely, this is the holy grail, looking for a single lab test that will tell you, no, this patient is going to respond very well, this patient is not going to respond very well. I don't think that is the way to go. But with artificial intelligence and a good integration of all the available data, I think there is no reason to believe that this kind of information can be produced, and that by doing so, we can move the field forward by designing clinical trials that answer meaningful questions. And with this, I would like just to recognize this. This is a part of a team in the research facilities. Pablo, Sandra, all the clinicians there, a lot of people working in the immunology core labs, and of course Nacho Valero, with whom I share a lot of fun, a lot of interest in liver cancer immunotherapy. And with this, I will stop and take any questions if you want to.
Thank you very much. For some reason, the host did not allow me to put a video on. I don't know if you can change it, somebody.
I on, Tim. You can do it now.
Oh, sorry. No, I can't.
It's blocked. And
it's blocked. But anyhow, so I saw that there was a question from Howard, I believe.
Yes.
Howard, you want to ask the question yourself?
Yes. Did any of the patients have cholangitis prior to HCC? And if so, how did they respond?
You mean primary sclerosing cholangitis?
Yeah, primary biliary.
Okay, no, none of the patients that we have treated have this as a background, I'm afraid. Not that I'm aware, and of course in the clinical trials it's not captured in the large ones, in the ones that the pharma industry runs.
So Bruno, this was very interesting, and obviously I have tons of questions, but before we go there, what I always miss is, and I wanted to know what you think about this, is, you and I, we are very much focused on HCC. But the field is much bigger than HCC. And, I think what we have to learn is that, HCC, don't say this too loud, but, HCC is not everything. And immune checkpoint inhibitors are used in many, many indications. And I don't think that any indication has ever found a biomarker. So I think this problem is very, is very different, not different, bigger than we believe. we would argue that, you don't have biopsies and etc. But, I just wanted to, think, what's your perspective? Why do we believe it will work in HCC if we haven't found it in any other disease?
Yeah. So one point is that, as I said, I don't think we will. I don't think the answer is this is the biomarker. This is the holy grail, the one lab test, easy to do. I don't think this is going to be the answer in the near future, even in the next future. But at the same time, I believe we by combining the different signals, there should be a way to say, okay, this patient has a 90% chance of not responding, which is important, or a 90% chance of responding, which I did not believe that was an important question 2 years ago. Now it is, because combinations comes with increased toxicity, and finding the patients that could do so well with monotherapy is also an important clinical need. My personal perspective is that I guess as much as you, I believe that if you move away from melanoma and non-small cell lung cancer with these high mutational rates, I think the answer has to be the same for all the other tumors as well. I don't think there is, and it's unlikely there is something unique in liver cancer that would, in terms of how it induces immune responses and how these immune responses can be activated. What is a different story is whether the liver provides an umbrella for immunotherapies, which is also a question that has to be explored, because I think there is data there that points that maybe an umbrella, a cancer protective umbrella, and we have not paid attention to that as much as needed.
Okay, so before I ask more questions, I have to let Shin first ask, and then there's 2 more from the chat. So.
Oh, thank you so much. So Bruno, there's always a very fascinating talk. And I like the phrase that Tim point that the Mr. HCC for the audit trial. And obviously that you have done so many. This is all fantastic for immunotherapy. But I'm just wondering whether you actually have identified a small group of patients that probably has very good durable response. So we can consider those as a super responder. Whether now you could really study those group of patients and try to understand why they are super responder as compared with the other. I mean, obviously you have those, population in hand, whether those efforts should really be put into for the study.
Yeah, so this is a very important point, I guess. So from our own perspective, we are collecting information on those patients. We're taking very good care of the samples, because I think we need to collect quite a lot of samples, and this is probably not a single center project. It has to be a multiple center project, because you need a good sample size to interrogate that collection in a meaningful way. We did analyze this in the CheckMate 040. And we couldn't find any particular signal there, but the problem is that the number of patients the immunohistochemistry was done in all patients, more than 150, but gene expression analysis could only be done in a few samples, and we are putting now our attention on the CheckMate 459 and the Himalaya and see what we can take from there. As much as that, I think, and we are collecting those, and are those patients with heterogeneous responses. Some patients that have tumor lesions that respond very well, while others do not, or some patients that have breakthrough progressions with single tumor locations. And I think, again, we need to collect those and do multi-center projects in which we can analyze a significant number of samples. So if you also have that kind of samples, that is certainly something we would love to collaborate with.
Yeah, we'll definitely encourage that. We're going to work together with that. We have some, but with a small scale. So that will be very fantastic. I like your idea about, collectiveness, working together as a group. So I'll be sure to email you, and then we get together. Thank you.
So, obviously, Bruno, you may know that we also have an interest in adoptive cell therapy with CAR T-cell studies. And Dr. Mone from our group, I think she has a question regarding your chemotherapy. You want to ask quickly, Cecilia?
Yes, thank you so much. I just wanted to know where the cyclophosphamide and fludarabine doses come from, because I think that's very interesting. We use a bit of a lower dose, and I'm just wondering where it comes from, because we're not getting to the lowest ALC probably.
Those doses came from the experience that Adaptimmune had in earlier all-comers clinical trials. And what I have to say that is there was an internal escalation. So in the first, because it was 6 patients, we used a lower dose of cyclophosphamide, and then we escalated to the one that you've seen there. And what I can tell you is that the lower doses did not result in significant cell persistence over time. So I do believe that cyclophosphamide dosing is important in terms of engraftment of the T cells.
Thank you so much.
Then we have a question from Alejandro Escobedo. You want to ask? The question is, would you use?
Yes. My question is the next. I read the question. Will the use of TGF-beta inhibitors also be good strategies to attack liver cancer and its microenvironment? And it's an excellent presentation, Dr. Bruno.
Well, thank you. That's $1 million question. So from a naive perspective, definitely yes. And when you look at TGF-beta signatures in not only in animal models but also in tumor samples, and we've done this exercise in the NASER trial, for instance, and certainly TGF-beta signatures are associated with worse outcomes. So inhibiting TGF-beta is always attractive as a combination. The problem is that the TGF-beta is so able to play dual roles that you can both activate or inhibit the immune response with TGF-beta inhibitors, because it can do as much good as it can do bad. And so there is also preliminary evidence. I can't remember what the group is from, in combining galunisertib with I think it's nivolumab, with not too good results. Again, still, I definitely think this is something we have to explore in the future.
So Bruno, now since I let all the others ask, I have 2 questions actually. So the first question is very obvious, which is you presented the data where you looked at the unpublished data on potential antigens, and you saw that there may be a favor for class 2 antigens, possible class 2 antigens, which obviously is something that caught my attention because that would require CD4 T cells, which is not the first thing to think about. Do you think this is something specific for the liver? Do you have any idea there?
Yeah, I'm struggling with the same perspective that you have. What I can say is that it's not only the class 2 neoantigens. Some of the data we have from gene signatures and cybersort also point at CD4 cells in that particular group of patients treated with SERD plus nivolumab.
Mhm.
So I don't think we can extrapolate to
Right.
these two settings. But the other set also point at CD4 T cells as key players in the enhanced immune response that translates into clinical benefit in this setting. How? This is something that I can't answer.
Well, you know,
Intriguing.
obviously, you know, the liver is somewhat specific because you can have priming of antigens by endothelial cells, which we don't have in other tumors. But I mean, that's just complete, you know, hypothesis. There's no data for this. The other question I have regarding this study is, so you mentioned briefly on the side that, you know, obviously with the yttrium therapy, you irradiate the tumor environment, and that may be, you know, disadvantage. So do you put your money on TACE plus immunotherapy rather than SERD plus immunotherapy then?
I will not.
Why
I will-
not? There's no radiation.
Yes, I look at this from another perspective, which is if we can identify beforehand patients based on T cell activation at the tumor microenvironment, then probably you would be able to select those patients that do not have an evolving T cell infiltrate as the best candidates for a combination, while you do whatever else. It can be immunotherapy, monotherapy, or TACE plus immunotherapy for the others. So I think, and of course, this is just food for thought for new trial designs. But I think I would like to see a trial design in which you select patients for radiation, or at least radiation schedule based on the tumor microenvironment.
Okay. So then, you know, I don't want to miss this, but Howard had one last question about, you know, are you collecting microbiome samples from your studies?
We have started to do this. We were not involved in microbiome studies before. We were just discussing with Anu on this. But, we are interested. We are not experts, but certainly I do believe that there is, based on all the signals, both from translational models, but also from this intriguing effect of prior antibiotic therapy, and of course, speaking to you, the trial with concurrent antibiotic therapy. I think there is the role of the microbiome has to be explored. So we are collecting samples. We have to do what we do with them.
All right. So thank you again. You know, that was an amazing hour. You know, how much better can we start the week than, you know, having Bruno give a talk on immunotherapy on HCC. You know, I can basically go home again. You know, this was just fantastic. Thank you so much.
Thank you very much.
Thank you, Bruno. Very nice.
Next time I'll present some really fresh data on some of the works I've highlighted here.
Okay. Take
Have a
care.
very nice weekend.
Thank you.
Bye-bye.
Thank you, Bruno.
Bye-bye.